exploration of data and racism and help ourselves as MCH practitioners to stay informed. Dr. Mendez is a professor who does research on racism as it relates to maternal and child health topics, and she's also familiar with the world of public health practice. She works closely with the Allegheny County Health Department, which includes Pittsburgh. We would like you to use the chat function or hand raising function to ask questions. And we'll try to watch for both of those. We'll save most of the questions for discussion time, but you can still ask them anytime. But Dr. Mendez is going to try to address questions for clarification as they arise. So welcome, Dr. Mendez. Thank you.
Thank you. Thank you for the introduction, and just thank you for the opportunity to be here with you all today. I'm going to share my screen. Give me a second. Great. So once again, thank you for the opportunity to speak with you all today and just provide somewhat of an overview and continuation of the important work that you all did last year related to racism. As was said in the introduction, I've been doing work in the area of Pittsburgh, Pennsylvania, or Allegheny County, in collaboration with a number of partners. So this presentation today is really in community, in concert, in collaboration with a number of people. And so the purpose of this session is to share with you all some approaches I've used in measuring and understanding racism, but also some key frameworks and questions that you and maybe your teams might want to consider as you continue to do the important work of measuring, assessing, and eliminating racism. But before I get into the core content today, I'd like to acknowledge that in this presentation about racism, it's important that we uplift the people who have lived and continue to live on the land, on various lands, one of which where I'm located, which is Pittsburgh, Pennsylvania, which occupies the ancestral lands of the Adena culture, Hopewell culture, Monongahela people, who were later joined by other tribes. This is the Delaware, Shawnee, and Haudenosaunee, also known as Iroquois, the Confederacy of Six Nations, which includes Cayuga, Mohawk, Seneca, and Tuscarora, who were driven to the region from their homelands by colonizers. And for nearly 40 years, Native children from across the United States were forced to attend the Carlisle Indian Industrial School in central Pennsylvania, not far from Pittsburgh. This was an explicit removal of Native connections, cultural identities, language, spirituality, and names. And this was actually used as a model across the United States with the goal of cultural genocide. And, although I provide this land acknowledgement today, it's not enough. We must continue our solidarity and work and sovereignty with Native Indigenous people throughout the United States, which includes decolonization and also in our role in the work that we do in public health. I also wanted to mention that December 10th, the United Nations has recognized as the Human Rights Day. This has been since 1948. And this year's theme for 2021 is equality, reducing inequalities, and advancing human rights. So for my presentation today, I wanted to start with just a brief recap. I know a number of you were engaged in the presentation on what is racism and just an overview and deep dive on, the context and what that means in this space of the work that we do. But I wanted to first ask if you can put in the chat who attended the workshop last year on racism and health, which was the overview. Hoping I can see the chat in my view. No one attended the session last year on racism and health? Okay, I have a one person, couple. Here we go. Awesome. Just want to get a sense, right? So I'm just going to do a quick recap. I don't want to go into, all of the content, but I will at the end share some resources for those who weren't able to attend that session last year, just to give you some base knowledge. Can you also put in the chat who has actually been engaged in work focused on measuring, assessing, that can include collection of data or developing action steps related to understanding and addressing racism? You don't mind putting that in the chat as well for me? Awesome. Great. Thank you. Great. Great. Thank you. Great. So a number of you have been engaged in this work. And I apologize if I covered the slide. I realized that you all can see the chat that I'm pulling up. So I'm going to pull that over so it's not in the way. Awesome. Okay, so then, another core element I wanted to obviously, which is the focus of today, is data and measurement. So thinking about this on multiple levels, individual, institutional, and structural. So I'll provide a little bit of background, some work that I've done in the past, and then 2 ongoing projects that I'm engaged in and leading with a number of collaborators. Then I'd like to end with some frameworks that relate to action and intervention. I'm hoping that some of these frameworks and questions and processes will be helpful for you in your work, not only in terms of how you might measure and assess, quantitatively structural racism or forms of racism, but processes that you can continue to think about in your own health departments or in your organization in general. Okay. So many are familiar with the language of social determinants. I'm sure you've seen a figure similar to this. This really lays out our, kind of rubric or framework for thinking about social determinants of health. And I have these percentages here because typically when I present this, I usually ask this question of, well, what percentage of our health is shaped by healthcare for the healthcare system? I get a range of responses. Some say closer to the 10 and 20%, others are saying 50, 80%. But we know that our health is shaped by a myriad of factors that go beyond the healthcare system being important, but one small element of that work. But as we think about the social determinants, for example, housing as a social determinant, as you saw in the earlier slide, we understand that inequities in housing exist for a reason, that racial inequities in schooling, racial inequities in the medical system or medical industrial complex, the prison system or prison industrial complex, that is for a reason. And this is where I'm referring to structural determinants of health, that these structural determinants point to the distribution of power and resources. Who has the power and who's making the decision? And we can think of this from the contemporary and historical perspective. These are the systems that drive inequities known as root causes. And for today, we're going to focus on racism, but we can also think of other systems such as classism and sexism and the intersections of those. So what is racism, right? That's sort of the focus of your conversation last year. But I include this Toni Morrison quote, right? Has anyone seen or heard this quote before? You can feel free to throw it in the chat if you have. But what she talks about is that racism, one, as we know, is a system, right? And it's benefiting certain people. And it will disappear when it's no longer profitable and no longer psychologically useful. And when that happens, it'll be gone, right? And I think that's very telling. When we think about racism as a root cause and what that means for health and how it shapes health. Now, many of you have seen this before, which is Dr. Jones's 3 levels of racism, a theoretical framework in a Gartner's Tale. For those who haven't read it or seen her videos online in which she explains it, I highly suggest you do. She is a wonderful storyteller. I know she's presented at this conference before. And she's someone who has an ability to take sort of this concept and lay it out in a way which helps to demonstrate sort of how these things manifest. And so in this framework around racism, we're talking about a system of structuring opportunity and assigning value based on the social interpretation of race, which unfairly disadvantages and unfairly advantages some communities and individuals. And in this 3-level framework, she talks about the institutions, laws and practices, personally mediated, which is typically what we think about, which is sort of the individual experiences with others. She uses the language of personally mediated because the institutional, and I would say structural, is mediated through actions from people, whether that's generation of laws or de jure de facto racism. And then also internalized, which is really accepting negative, negative beliefs about a particular racial group or your own racial group. And so I like to use this framework as well to really lay out the ways in which we think about public health research, policy, and practice, and then health equity specifically. Some of you may be familiar with this tier 1, tier 2, tier 3 framework or generation framework in which we can talk about descriptive epidemiology or detection, right? We do a great job of documenting what the disparities or inequities are, right? Then that next is understanding what the contributors to those disparities or inequities, and then what do we do about it? What are the action steps, the interventions and policies? And then tier 4, which is really, I say, embedded in all 3 of the tiers 1 through 3, really bring to bear critical race theory. So this is an extension of that, which is public health critical race practice, which I'll talk about in a minute. But it's really this key framework of centering racism as a key foundational or root cause for racial inequities in health. And this is critical for us to think about this framework as we move forward, not only in this presentation, but the reasons as to why would we consider racism as a fundamental cause of health and health inequities. So public health critical race praxis was framed and developed as I mentioned, an extension of critical race theory. And here are the 2 people who have developed this work, really important scholars in the area of public health research and practice. And what they say is public health critical race praxis guides health equity researchers and practitioners in going beyond documenting health inequities, right? That's that tier 1, in order to explain and challenge the power hierarchies that undergird them, right? So this is where we're getting into the structural racism that I mentioned, or structural determinants as it relates to power and position in decision-making. And so the starting point of critical race theory and public health critical race praxis is that racism is an ingrained feature of American society, right? So that's what we're starting from. It's not a question of, does racism exist? Is it embedded in our systems and our ways? That is the starting point. And it has both historical and contemporary connections and implications. That is not limited to discrete acts of overt discrimination. And it also challenges this colorblind notion that if I'm quote unquote, using this language of colorblind to mean absence of racism, which we know is false. Another key element that I'll talk about as well is centering on the margins. And this is really focusing on the experiences of the people who are systematically oppressed and excluded. So centering their experiences, centering their voices, and in the decision-making process. And this is where the community-driven praxis comes in. And I know you all have talked about that earlier today and will continue to through the conference. And then there's also final critical self-reflection on the part of the researcher, practitioner, and advocate. And we can say an extension of critical self-reflection of organizations and institutions as well, and the people within those organizations and institutions. So I wanted to start with centering on the margins. So for many who may or may not know, CRT was developed by Black feminist theorists who were really concerned about the ways in which Black women and femmes were, their livelihood and their well-being. And this is where praxis, both from critical race theory, Black feminist thought, and intersectionality comes to bear, and thinking about racism and sexism. And carrying this forward, we can ask, what does this mean in terms of health? And so once again, this is focused on the experiences of people who are systematically oppressed. Those research and practice teams are intentional about centering on the margins in all areas, including who is actually conducting the work. So you can ask the question, who is on your team? Who's conducting the work? Whose voices are being centered? And then another key element is counter storytelling and narratives or lived experiences. So for those who in this audience who are using mixed methods, who are using multiple approaches as epidemiologists, I say I use a multitude of methods. There's a multitude of tools, right, in our toolbox to do this work. And counter storytelling narratives are critical, right, because that also gives us the context to some of the quantitative data that we use on a daily basis, right, or that we might think about and use in our respective organizations, health departments, et cetera. And I like to really lift up and coin some of the work that Dr. Diane Rowley has done, really shaped my career. Actually was a mentor of mine as an undergrad at Spelman and on to graduate school, where she really flipped this question on its head, right? This question of, well, why are Black women more likely to have an infant death, for example? And she said, well, let's flip that question, not to, right, mother blame or person blame or, center in that way, but to say, what are the experiences of Black pregnant women and birthing people that shape their health? What is it about living in a society, in an environment, right, that is racist and sexist and also is uplifting multiple forms of oppression that disproportionately affect Black pregnant women and birthing people, for example. So those were the questions, right, that she was asking, really flipping that on the head. And so what are the implications for research and data centering on the margins, right? So we don't have breakout rooms. I know some of the other skills building sessions do, but I do want you to think about these questions, right, in the work that you do, right? In your respective divisions, departments. I know many of you collaborate outside of your organizations to be able to conduct the work that you do, right? So who is the focus of that work? Whose interest is being centered? Who is conducting the research, right? Who is on the team, collecting the data, engaged throughout the process? What questions are being asked in the first place, right? And from that, I always talk about, well, what are the frameworks that you're using to even come up with the questions in the first place, right? What knowledge, what narrative is being elevated to even come up with that question that you might be asking, right? And then once again, what methodologies are being used, right? We can go into this whole conversation on methodologies that are, sometimes given more, prestige, if you will, or support than other methods, right? But there are a variety of methods that are useful and critical when we're doing this health equity work. So I wanted to show this because this once again demonstrates the question that Dr. Rowley was asking in some of her early work, right? Focused on racism and pregnancy and preterm birth. And this is really about thinking about the counter narrative, right? Many of you have seen a similar graphic before, right? Something similar maybe in terms of infant mortality or morbidity. And this is basically showing pregnancy-related deaths per 100,000 live births by education. So it's racial inequity by education as well, right? So some of this might be relevant for you all who might be engaged in work around perinatal periods of risk, where you're asking the question, like, what are the root causes? What are you seeing in respective communities and states, et cetera? But if we were to revisit, right, and unearth this data, we can see that, the question of, right, so the question becomes, is it education, right, that would close the gap, right? And we know that education alone does not close the gap. And we can actually see here, when we compare Black and white individuals, that disparity in pregnancy-related death is actually 5 times, right? And when we look at American Indian, Alaskan Native, for some college compared to the group in high school, right, we see that there is a gradient and a slight decrease, but white women with less than a high school education are still less likely to have a pregnancy-related death. Right. So this really points to the fact that there is more happening than just saying, oh, okay, education is what explains this. So many of you have looked at similar data, but this is really uplifting this question of, what what have decades of data shown us, and what are the questions we are not asking, right? So this long history of oppression and racism puts into context what we see today. Many of you might be familiar with the Lost Mother series. There's a number of you I saw on this call who've been engaged in some of this work for quite some time in your respective areas. And this is really, speaks to, I would say, the power of media, multiple media sources actually coming together to talk about maternal health and maternal death in the United States. And so, this top picture here is of a friend and colleague, actually fellow postdoc scholar with me in the Kellogg Foundation and Kellogg Health Scholars Program. And she was CDC officer, public health expert, specialized in health equity. I know several of you on this call may know her as well. And she died shortly after childbirth due to complications from high blood pressure. Many are also familiar with what Serena Williams has talked about, other celebrities as well. And, there are countless examples of Black, Indigenous women who talk about their pain, symptoms, or even basic desire of care as being dismissed and discarded. So this speaks to not only the cultural and structural racism that exists in our systems, but what does that mean for long-term health and care, right? And so this is once again really uplifting the narratives. I wanted to show another example from a colleague. This is a conceptual framework that she developed, really centering once again the voices of Black women and femmes in her region. This is Dr. Brittany Chambers in California, conducting community partner, community-based qualitative work, where this framework was developed to really, draw out what are the ways in which structural racism is showing up for Black women and femmes in the region. And so these are some of the core elements, right, that came out of this work, from structural racism in the medical care system, law enforcement, education, policing, but also talks about hidden resources, right? Lack of knowledge or availability of community resources and what that means. So this is a framework. I include the citation here for those who'd like to read more. So also an example of a counter narrative has been work that I've been engaged in Pittsburgh. And so there was a Gender Equity Commission report by the Gender Equity Commission of Pittsburgh on inequality across gender and race. And this report found that Black women had the worst outcomes in multiple areas, ranging from health to economic opportunities, compared to the white counterparts in Pittsburgh. And this was actually worse compared to some other quote unquote comparable cities, right? And in response to this report, a collective of Black women wrote a response letter to bring attention to the report's process and content that lacked any significant level of leadership from Black women and femmes, that not adequately reference the current and historical impact of gendered racism, and center the scholarship of white women researchers and scholars in validating experiences of Black women and femmes, right? And so, this was critical because this response, one said, we can claim that Pittsburgh's the most livable city, but for who, right? And when we're talking about this process of documenting, understanding racism, we say nothing about us without us, right? At the same time, this report has been used to develop or support legislation around racism as a public health crisis in the city of Pittsburgh. And so this actually happened in December 2019. This was a little bit earlier, actually right after Wisconsin, not long after Wisconsin had passed several pieces of legislation related to racism as a public health crisis. And so I'll come to this a little bit later. But one of the things that we cited, one of the key areas that we cited was from the Black Mamas Matter Alliance, which once again, when we think about data, we think about narratives, when we think about our approaches and frameworks, this is one that I want to uplift, right? This is really advancing holistic maternal care for women through policy. And one key area that we noted in our response letter was to identify and ensure the mechanisms for engagement and prioritization of Black women and Black-led entities in the policy and program development implementation, including the development of that work and that research from that report. And that included ensuring what they talk about is ensuring Black women are prioritized, participants at every level of decision-making, investing time and resources, financial resources, and then also applying an intersectional lens. This led to some local work that is ongoing that we're developing in my region with colleagues in several community organizations, as well as our health department called the Black Women and Femmes Health Project, an intersectional systems approach and reproductive justice lens, where we're really interrogating the systems, institutions, and organizations in our region and asking the question, how are they centering the lives and experiences of Black women and femmes in the development of and execution of solutions? And this is just a figure of the key elements that we're examining, from funding, policy, and organizational structure in our region. And I can ask questions, answer questions later for those who might have them. We are completing an environmental scan, and we're using several tools for equity assessment that are founded and based out of this sort of framework around public health critical race praxis and critical race theory. R4P, some of you may be familiar, developed by Hogan and colleagues. I'll actually talk about that a little bit later. Hogan, Rowley Institutional Measure of Equity, and the Brooks Equity Typology. These are just some of the tools that we've used, including tools and development from GARE, many of which you are familiar with. So if we were to go back, right, to the earlier slide of CRT, public health critical race praxis, it's a starting point that racism is an ingrained feature of American society that has both historical and contemporary connections and implications. This is one figure that I usually like to uplift because it provides a timeline, right, and some historical context for social experiences of African Americans and American descendants in the United States. And in this scholarship in particular, it's within the context of a review related to sexual and reproductive health, right? And so when we think about the effects of racism, we think about generations of oppression and the examples of that in these various sectors, systems, and institutions over time, right? We can begin to think about how these all come together to influence not only health across the lifespan, but also over generations. So this next part of the presentation, I wanted to provide some examples and talk a little bit further about data and measurement related to racism. But before I do, I'd like to ask if you can, in the chat, you can share some specific ways that you have assessed or measured the impact of racism on health outcomes, on sort of maybe the larger body of work that you're conducting, or maybe you've taken a systems approach to looking at the impact of racism maybe within your institution or organization. Any examples? ICE, yep. Racial segregation, right? So some institutional structural measures. I'm going to actually talk about some of these. Anyone else? Yep. So some self-reported measures, right? Great. Wonderful. So I see questions about experiences of racism in your MCH surveillance surveys. Awesome. So I would imagine, you're doing your population surveillance and also collecting the self-reported data about experiences of racism. Qualitative, someone said qualitative techniques. Yes. So, and I don't go into this. I'm glad this person Lauren brought up how we document race and measure race and ethnicity, and going beyond the white, non-white dichotomy, or even centering whiteness, right? Like using white as the reference group all the time. And actually in our local process of PPR, we talked about that. It's not to say you don't compare across groups, but why do we always center, white, as the population? when in many cases our outcomes for white individuals are not phenomenal either. Let's see, vital stats. Maternal death review, right? Absolutely. Self-reported experiences. Yeah, maybe when we get to the Q&A, I'd love to hear a little bit more about how you are including a maternal mortality review, death review. Barriers and facilitators among tribal colleges. Thank you. Thank you all for including these examples. Prams, yes. Absolutely. Perfect. Thank you so much. You can keep writing them in, just so you all can share this with your colleagues too, as well. This is awesome. Thank you. So I'm going to do a little bit of background talking about institutional racism and some ways that I've measured it around residential segregation and redlining, talk a little bit about structural and social determinants and measurement there broadly, and then give an example from some of my work related to individual and structural racism. Okay, so in that sort of 3 levels of racism that I showed earlier with Kamar Jones, the first I wanted to talk about was institutional racism, right? So this is referring to differential access to goods, services, and opportunities of society by race. And this can be codified in customs, practices, and laws. And I include this quote by Dr. David Williams, also a researcher who's been leading work in the measurement and understanding of racism and health. And one of the things that he talks about is institutional racism being arguably the most important mechanism by which racism affects health. But it's challenging to capture in traditional epidemiologic research, and we have not fully quantified the impact of institutional racism on health. And I say we may not actually be able to fully quantify, right? How do you quantify the context, the contemporary context, the historical context over generations, right? How do we completely capture? And I'd say we probably could never really capture it in one epidemiologic study versus a series. Not to say we shouldn't continue to, but then the question becomes, does that mean we don't act? Because we can't capture everything in a study, does that mean we don't act? And I say, no, we do act. And then structural racism is the macro level systems, social forces, institutions, ideologies, and processes that interact with one another to generate and reinforce racial inequities, right? So we can think about these multiple institutions coming together, the totality of ways in which they impact health, right? And so some of the key ways in which we've identified and measured racism or structural and institutional racism in research or epidemiologic studies specifically has been around sort of this geographic measurement. And in the context of neighborhood context or location and geography, residential segregation and redlining. So for those, there are a couple of you, I think in the chat mentioned you've done some work on segregation. But when we refer to segregation, we're talking about the physical separation of racially distinct neighborhoods and communities. This was historically done to ensure whites were safeguarded from residential closeness to communities of color, redlining as well, which I'll talk about. And although redlining and segregation have been illegal with the passage of the Housing Act, Fair Housing Act in 1965, it's still reinforced and perpetuated through similar policies and practices, right? We could think about gentrification, current development, right? Displacement. Another is mortgage or subprime lending, right? And so we knew between 2005 to 2009, the median wealth of like households declined by 16% compared to Black households of 53%, Hispanic households of 66%. So we actually had a subprime targeted lending during our housing bubble. And we know there are many court cases that came out as a result of some of the very prominent financial institutions targeting communities of color. Fast food or food lining, right? We can talk about higher costs in Black zip codes, for example, incarceration and prison industrial complex, immigration policy from historical to contemporary, right? And so these are a number of ways in which institutional racism has been measured to some degree in health studies, and it continues to as well. And so once again, redlining was just one example of an institutional measure of racism, one of which that I've applied in some of my own work. And we think about redlining, it not only encompasses the direct refusal to lend in minority communities or communities of color, but it also procedures that discourage submission of loan applications for those specific areas, and excluding those areas from the market. And in direct economic terms, racial redlining reduces housing finance options, it weakens the competitive mortgage market. We know it's linked to long-term, wealth attainment through home ownership. And so in this figure here, this is actually a map of a HOLC map, Homeowners Loan Corporation map from 1937 in Pittsburgh. So for those of you who are around the country, haven't seen a similar map, I'm sure you can find one either in your state of a core metropolitan area in your state, or even in your own city. And so in these redlining maps, the 4 meant hazardous was usually coded red. And so that's where that comes from. And this was coined at a time when, we had the Federal Housing Authority, which were not, backing loans and supporting home ownership in Black communities and communities of color. And so in some of my early work on institutional racism, we were examining the relationship between redlining or mortgage lending inequities and pregnancy outcomes. This was built on work that was conducted based in Philadelphia, the Stress Pregnancy Environmental Community Survey, which was led by Dr. Jen Cohane, colleague Vijaya Hogan as well. And we were developing new measures of residential segregation as a means for understanding the impact of institutional racism. And so I include the citations there just as background. But just to give you a little bit of a sense, we were developing this measure of redlining, mortgage lending index using the Home Mortgage Disclosure Act data. This is data that is available across the country. The smallest geographic unit for this data is a census tract. And it includes information about the origination of the loan, whether the loan was approved, some characteristics of the applicant, the actual location as well. And so in our measurement, we were looking at the probability of non-Hispanic Black applicants being denied a loan compared to Black applicants. And this was through a Bayes estimate, if you will. We can get into the methods, but random effects model to calculate this for each census tract in the region, right? We were able to adjust for some individual information about the applicant, as well as loan amount to income ratio. And when I initially did some of these analyses in the Philadelphia area, this was prior to them adding, content around credit history, but also what we consider rate spread. And rate spread is where we could pick up, the issues around subprime lending, right? In our analyses, we excluded incomplete applications, properties that were not owner occupied, home improvement loans, and multifamily units. So I just wanted to give you a figure of what this looks like using more contemporary data from 2003 to 2011, with the darker region showing the inequality index or inequity index, if you will, of mortgage discrimination. So a 2.3 means that Black applicants were 2.3 times more likely to be denied a loan after controlling for, the characteristics that I mentioned. And once again, it was excluding sort of these home improvement loans, multifamily units, et cetera. So next I wanted to talk about collaborative project in Allegheny County with the county health department as our backbone, Allegheny County Health Department, partners at the University of Pittsburgh, Sustainable Pittsburgh, which is a sustainability organization, Black Environmental Collective, and our Live Well Allegheny CDC REACH initiative. And so we have a CDC REACH grant. We are a newer grantee. This is going into our 3rd year. I know many other cities or counties have had REACH support and funding for quite some time, but I included all of our partners in our website for those who are interested in reading more. And so we have an ancillary grant that is really using our REACH initiative as the backbone to develop additional measures and understanding around structural and social determinants and linking that with our core REACH communities. Our REACH initiative, as I mentioned, in Allegheny County, focuses on 6 African-American communities throughout the county. And in our particular analyses here with the that was funded by the Hillman Foundation, we're looking at social, physical, and structural environmental factors. Cardiovascular risk outcomes are the main outcomes, but you can imagine, and I'll show you an example, we're linking in a number of health outcomes across the REACH communities. In addition to development of the metrics and really looking at what is happening on the community level in their 6 REACH communities, but across Allegheny County, we are working with Sustainable Pittsburgh, which is a new partner to the REACH initiative, but they've been conducting work in our region for quite some time and are experts in really thinking about municipal leadership and working with governmental leaders around action. So this is really the data to action piece in terms of being able to use this data to inform engagement, inform municipal leadership around actions that promote health equity or racial equity and then health equity. And so just really briefly, Sustainable Pittsburgh's mission is to influence decision-making in the Pittsburgh region and integrate economic prosperity, social equity, environmental quality. And then the goals, as I mentioned a little bit earlier, was to develop our tools and metrics in the REACH communities, that these results are informed by and shared with our partners, including our newer partner in this particular initiative, which is the Black Environmental Collective. And then once again, data shared with municipal governments to inform decision-making. Okay. So these are some of the key metrics for consideration, and you can imagine, many locations, you are from multiple locations that are collecting surveillance data, perhaps in your region. We have a surveillance system, surveillance data that we collect every several years. We're advocating for additional collection and surveillance of key chronic disease outcomes. Also working with partners in our Family and Child Health Division on having our own local prams, right? So additional surveillance of health is one kind of core area that we're working on and developing. But we do work with our local healthcare systems in order to access, de-identified data on the community level related to similar health outcomes. And here are a few listed here. We work closely with the Western Pennsylvania Regional Data Center, which is through the University of Pittsburgh Center for Social and Urban Research, where they are, they've developed a number of relationships across multiple organizations and institutions in our region to not only have data available to the public to use, but they also are leaders in, ensuring that community is able to access that data, provide technical support and training. The table to the right is the locations of our core 6 communities from REACH. And so this is just to give you an example of prevalence of cardiometabolic outcomes in our county, but also within our specific REACH community. So these are just some of the data that we were proposing to use and map with the understanding that there was a need for additional surveillance that goes beyond the scope of this project. Key metrics of consideration, both from the structural and social determinants of health, included food establishment data, some of which could come or has been able to come from the health department, but also through our Western Pennsylvania Regional Data Center. Other measures from the US Census, many of which you are familiar with, and then data related to land use, parks and green space. And then I mentioned Home Mortgage Disclosure Act data, which is also public data related to understanding discrimination in mortgage lending. So these were some of the things that we were proposing. This next slide is really to break down a little bit more of some key metrics that we are developing and designing in our data tools and in our communications and collaborative work with municipal leaders and municipal leaderships and community organizations, both through REACH Sustainable Pittsburgh, and the Black Environmental Collective. Some of which are population demographics coming from, U.S. Census, American Community Survey data, measurements of segregation. So really looking at the distribution of communities and what is accessible. Neighborhood income, education, and employment. Data around housing, such as age of housing. Sidewalk data, walkability indices. This includes percent streets with sidewalks, linear sidewalk miles relative to streets. And this speaks to some of our work that we're conducting in collaboration with the Office of Economic Development and several municipalities throughout Allegheny County. Flood and landslide risk as well. Housing building code violations. Environmental Justice Index, which has been developed by our county health department, as well as several key health outcomes. And then to the right, this includes some key action steps, right? So these stem from equity action steps that have been developed by a number of partners in the region and across the US around, the ways in which municipal governments may think about, the ways in which they would move forward, how this data could potentially inform. And here are just a few of the action steps here. So, municipalities actively developing and maintaining bicycling and walking trails that connect with community assets, right? So that's one specific municipality action step. And, one could imagine a number of data sources that relate to this, from sidewalk and walkability, but also traffic patterns. Alternative forms of transportation are accommodated and promoted, also related to the first. Measures are taken to ensure a wide range of candidates are interviewed for municipal job openings. And one of the things that we discussed is, when we're centering on the margins, if you will, or centering the communities disproportionately impacted, what does that look like in terms of municipal decision-making, right? And so what are the population demographics? What are the distribution within the population? And what does that mean in terms of organizational structure? And we could think about that even from, I would say a university academic setting and public health setting, right? Municipality has performed or participated in a regional assessment of hazards and potential risks of climate change. So this is another key action step. And so many of the action items that we have, that we've developed, or not developed, that we are actually using in this process, we're mapping back to what are the data sources that would at least point to and help support municipal leaders in their process. Okay, great. Okay. So I wanted to move on to an example of some work I've been leading and conducting in collaboration with a number of investigators and partners in our region, once again, in the Pittsburgh, Pennsylvania region. And this is through the Postpartum Mothers Mobile Study. And we know from previous work that postpartum weight inequities, as well as disparities in cardiovascular risk, cannot be easily explained by traditional risk factors or even weight prior to pregnancy. And, we know that a lot of the work that has been done also points to the fact that, among women who enter pregnancy at a normal weight and gain within recommended amounts during pregnancy, that there's still inequities even with respect to postpartum weight. We can think about, in general, health during the pregnancy period and beyond, thinking about the ways in which our systems are designed and set up to support health to some degree during pregnancy, but not during the postpartum period. And so PMOMS combines, prior and current work in this larger perinatal health framework, but also work related to real-time data collection through ecological momentary assessment and mobile technology. And so one of the primary, approaches is EMA coupled with GMA, which is really thinking about context and environment in real time. So what are the environmental stressors, including racism, that are influencing health throughout pregnancy and after pregnancy? And then the secondary purpose as well is to think about what are the key points of support and intervention, right? Within the context of pregnancy and postpartum. Oops, Sorry about that. So I wanted to just mention this one example here. If you're interested in reading a little bit more about the PMOM study, this is the website. We do have several of our publications on the website. And so in this publication in particular, we were assessing and understanding stress, racism, and other forms of discrimination in real time. Our cohort or our study was focused on, as I mentioned, the pregnancy period. This was an ancillary observational study to a clinical trial called the GDM2 study led by Dr. Issa Davis, in which they were assessing two strategies for testing gestational diabetes and its impact on infant outcomes. And so PMOMs was, leveraging or included within that larger trial, following women and pregnant people through pregnancy and through 1 year postpartum. And one of our main modalities I mentioned was via smartphone technology. So assessing people's experiences in real time and in their natural environment. And we started this study before the pandemic, around 2018. And when the pandemic hit, because of the way in which we were actually collecting our data primarily through remote sensing, we were able to maintain contact with participants throughout the process or throughout the pandemic or early in the pandemic. This is an example of the questions. We had questions via smartphone at the beginning of the day, at the end of the day, and then random assessments. Our random assessments included questions about racism, microaggressions, and other forms of discrimination. And here's an example. Today, how often were you treated unfairly than other people because of your race? In the study that I just showed you around ecological momentary assessment of racism and stress, what we found was that Black women and birthing people reported an average of 2 experiences of racism per day throughout the duration of our study. And white women reported an average of 1 experience per day of sexism throughout the duration of the study. And so this really points to one, kind of recall of experiences, but also the chronic exposure of stress, racism-related stress, sexism, gendered racism, and what that means during the pregnancy and postpartum period. This study, we just finished data collection a few months ago, so we have not looked at sort of the impact of racism on health outcomes at this point, but this really just demonstrates the sort of larger context in which women are self-reporting in the ways in which racism is showing up in their daily lives. I wanted to show these as well. The first, everyday and major discrimination, we actually include as well in the PMOM study. A few of you have mentioned that you are collecting self-reported measures of racism with your surveillance systems or within your divisions. And so these are just a couple of examples, and we can talk more that many of you may be interested in incorporating. So the everyday and major discrimination scale, this first one is really capturing how often things happen in your day-to-day life. The major discrimination is capturing like major events, such as being fired, denied a promotion or a bank loan. And then it asks for a follow-up question about the reason why you think that happened was because your race or gender. And then the experiences of discrimination scale by Krieger, which is capturing interfaces with institutions. So I usually think of this one as self-reported measure of experiences or interface with institution or institutional racism based on those interactions, right? So in addition to the individual self-reported experiences, which are critical for us to understand as it relates to experiences of racism, there's also the structural racism. So we have a new supplement for the PMOM study in which we are expanding our measurement and assessment of structural racism within the cohort. As I mentioned, we are collecting data in real time via survey, or were at the beginning of day, end of day. and random assessments. And in addition to that, we have a prompt where the participant can also decide if they will allow us to, basically mark their location. So if they're completing that survey, it's also pulling in their location, which allows us to then link in any secondary data, right, related to, some of these measures of structural racism, some of the other measures that you all mentioned in the chat as well. Right, and so this multidimensional measure of structural racism, I wanted to uplift this recent paper by Dr. Chantarant that came out earlier this year, which is a multidimensional measure. So thinking about these individual measures and how do they co-occur. And in this multidimensional measure of structural racism, it includes Black-white residential segregation, Black-white educational inequity, Black-white employment inequity, and Black-white home ownership, and then Black-white income inequity, index of concentration at the extremes, which I think someone in the chat mentioned. And in this paper, they're really arguing that, these unidimensional measures of structural racism are critical and important, but they co-occur, that they interact, and it's important that we, think about the multitude of ways in which structural racism shows up and influences health. And these measures actually are stemming from American Community Survey data from 2019. So many of you could potentially replicate something like this in your own region to get a sense of what does structural racism look like in our county? What does it look like in our state or across our state? And then what would it look like over time? Like, could you, essentially assess these measures from US Census data from, 2000 or 1990 and carry that forward to the present? And so we are expanding on that multidimensional measure that was published in our PMOM supplement by including several other measures. One, thinking about racial inequities in physical and built environment. So I mentioned the Environmental Justice Index, which is an expansion of the index by our county health department. We have inequities in environmental exposures. Our air quality actually in our region is some of the worst in the country. We are known as historically as a steel town, but continue to produce. And there are particular communities that are disproportionately affected in our region, but it also affects air quality across the entire region. We also have the Black-white inequity and walkability, which I mentioned earlier, transportation inequities, housing inequities in terms of affordability, age of housing, healthcare inequities. This is Black-white inequity in primary care as an example, but there are a number of other metrics that we are considering in this multidimensional measure, and then incarceration, Black-white inequity of population in prison. So I just wanted to give you an example of what this tool looks like. And if we get to the Q&A, I can kind of show a demo of it. If for those who are interested, but this is once again in collaboration with our partner through the Western Pennsylvania Regional Data Center. And so they have this tool, community profile tool that they have been developing. I'm sure many of you have seen similar tools or developed similar tools in your own region. But what it allows us to do is to take those metrics that I listed, include them in a portal that allows for some level of interaction. So not only in terms of, what are the overall, metrics for that region, but we can drill down to even sub-region, right? So within our county, we can look at certain metrics with respect to neighborhoods or municipalities. So Pittsburgh, Pennsylvania is made up of 90 neighborhoods, close to 90 neighborhoods. And then we have more than 140 municipalities throughout the county. So we can look at municipality/neighborhood. We can look at census tract, and you can see the tabs across of the different metrics. So this is still in development, but this will be a tool that we'll be able to use, and also for our REACH community partners as we continue in this work through the CDC REACH, but also in collaboration with our Sustainable Pittsburgh partners who have been really leading work around collaboration with municipal leadership and decision-making. And then finally, in terms of measurement and structural racism, I wanted to just share a new, right off the press, just published today. My colleague, Rachel Hardiman, who led this paper, had the opportunity to work with a number of folks on measurement of high police contact in the neighborhood. So, a measure of structural racism in terms of high police contact and its association with preterm birth. So once again, this is thinking about geographic distribution and how that shows up in terms of structural racism in institutions and its effects or relationships with pregnancy and birth outcomes. Thank you. Saw the congrats. Thank you so much. And this is an open source, so I include that as well for those who are interested in reading more. So I wanted to end with just a bit around some frameworks for action and intervention. There are a couple points that I mentioned earlier that hopefully were helpful in terms of thinking about some of the frameworks on the fourth generation, right, public health critical race practice, how that's critical in the ways in which we think about data, the ways in which we use it, the ways in which, you know, data is generated in the first place, right, both the qualitative and quantitative work and mixed methods work, and what is actually highlighted. And so with the tier 3, right, also integrating the tier 4 public health critical race practice, we're talking about interventions and policies. So how do we eliminate inequities, right? What actions do we take? When you think about that, maybe you pause for a second. What are the ways in which your organization has taken action to eliminate health inequity? What portion of that work is specific to naming and addressing forms of racism, structural racism and otherwise? Do we focus more on what's feasible? Because some say, oh, racism, sexism, those are systems, large systems of oppression, like that's not feasible, right? Versus impact, right? And do we wait until we have all the evidence before taking action, right? And so this is really this conversation around quote unquote evidence-based practice. We know that evidence-based practice is a component. Social determinants of health a lot of times are not always incorporated in our framework around evidence-based practice, right? And even beyond social determinants of health, right, we have structural determinants, right? Who is in power? Who's making the decision? The structural determinants influencing the social determinants. And that is what led to this. So this is work led by Dr. Vijaya Hogan and colleagues called the R4P framework. Can you just indulge me in the chat for those who have seen this before, are familiar with the R4P or read about it? I believe Dr. Hogan has presented in the past. I know she has. Yes, yeah, lots, yes. Awesome. So there's a handful of yeses, but I'm sure there's folks who haven't. So I'm gonna go through, and like I said, I include citations for those who'd like to read more. Any no's? I see a lot of yeses. Yes, awesome, okay. So R4P is a theory of change for designing an equity approach, right? And it's really about reversing unfair, avoidable consequences of inequity. And a core element is dimensionality. And dimensionality really points to time. When we think about time, we can think about the life course. We can think about over generations, right? And so time is really taking into account the fact that in order to address inequity, we have to go back, right? We have to go back in the past. We need to think about what's happening over generations and understand this larger context of what we do today has to be within concert with our past, and the long history, of oppression that has affected our health today. And so this framework was generated from work incorporating Black feminist theory, intersectionality, and critical race theory. And this is premised on the idea, that structural change will have to take into account time, as I mentioned. And as I also mentioned, these evidence-based practice of just raising all boats, right? Social determinants intervention, just raising all boats. In order to achieve equity, we're going to have to consider the historical context and centering the groups most disproportionately impacted. Excuse me. So these are the 4 areas. I'll break them down a little bit further, but it's repair, restructure, remove, remediate, and then provide. So this is juxtaposed with the BETS equity typology, which I think are interesting and important questions, right? And so I include this citation here, thinking about the ways in which each of these areas of the R4P map onto what we can do, the questions we can think about in our organizations, the data that we can collect, both internally and externally, right? What are we doing internally in our organizations? And then in turn, what does that mean for outcomes, right? So these are really the questions to think about. And so repair is the past exposures, right? When we think about repair, we think about reparations, we think about the past, right? We think about Tuskegee syphilis is one example they include here. At my university in particular, our inaugural dean of my school of public health was Surgeon General during the Tuskegee syphilis experiments, or the public health service experiments, really, right? Let's name who was doing the work. And so we had a removal of Dr. Thomas Perrin. We had a session at our school to really identify and talk about it. Dr. Bill Jenkins actually came to Pittsburgh to talk about it as well. And this is really talking about what are the ways in which, as an institution, we've actually wreaked havoc and damage, right? And in many ways continue to, right? So that's important, right? I mentioned the Indian boarding school in Carlisle School in Pennsylvania, right? And so this is really, do we actively recognize and discuss historical disadvantage? Because part of the argument is, oh, we shouldn't talk about it, we shouldn't bring up old stuff, we should, but no, it's acknowledging and saying, this is what was done. And I say, even as someone who is coming from a community, I identify as a Black woman, coming from a community that has historically experienced this, I'm also at an institution, right? And so what does that mean when I come to this work, right? I'm also representing sometimes an institution. Do we actively undo or remediate historical disadvantage? Do we improve participation by improving quality of services, right? So these are some questions to ask. Restructure, right? So this is, as we are attempting to repair, identify, understand, discuss historical context, right? We're also restructuring, right? Which takes time, right? That's the processes, what decisions that we make within our organizations, right? And the structures, like that could be hiring policies. I mentioned one from the action toolkit, right? That we're working on with Sustainable Pittsburgh. But the question is, who are we centering, right? Who is at the table, right? And how is the table formed in the first place? Do we pass over groups identified by race because it's just too hard? Do we omit, exclude, forget, triage? Do we allow one population group to be left in undesirable circumstances, right? I'm sure for me, these questions, I continue to think about COVID. COVID is the tip of the iceberg for many things: structural social determinants, structural racism, oppression that has existed for decades. And COVID unveiling more of that, right? And opening more of that, right? Exacerbating it as well. Also disproportionately putting obstacles in path for and imposing punishment or limitations, right, to certain groups. Remediate, right? So can we buffer, right? As we're restructuring and addressing historical context, right? What are we doing right now, right? So a lot of times this can be thought of as sort of the primary prevention. But what are the ways in which we approach that work? Do we neglect to help people in face of need, avoid people or places, fail to provide timely and accurate information, neglect and marginalize people because they're unable to participate in ways that we deem acceptable, provide alternative strategies, and consider the positive, negative consequences. So remove in this framework, Hogan and colleagues decided to have remove as its own separate one because it was important to name racism and other forms of oppression. Also are embedded right in the other R's that I mentioned, but to explicitly talk about racism, naming it, how do we understand whether and how it's operating here? How can we undo the power imbalances and different advantages within the organization, program, or team? Right, and so here are some of the key questions related to that. And then finally, provide, right? How can I provide culturally, socioeconomically feasible interventions that families have the tools and resources carry out a recommended care plan, right? So juxtaposed with the best equity typology, do we systematically usurp or tie up people's time and resources as a requirement to receive the services? Are we considerate of, centering the populations, right? When we center the populations that are more likely to have challenges, that also supports the overall population, right? So what are we considering when we develop this work, when we collaborate with partners, and also ensure the decision-making processes are centering their experiences, their voices throughout. So that is the R4P framework. As you all, some of you said in the chat, you've used it, you've applied it. Interested in understanding how you all may have applied it. Our local coalition has applied it in some of our work. I've been engaged in applying R4P and thinking about, as I mentioned, our environmental scan and assessment of what's happening in our county in terms of supporting Black women and femmes and health and well-being across the lifespan. And then I wanted to just share this here, Racism is a Public Health Crisis, Assessment and Review of Municipal Declarations and Resolutions across the US. I'm curious as to whether anyone in the group has been engaged in any of this specific legislation, whether you've spoken to your legislative body about racism, whether you helped to write the legislation yourselves in your region, or any other efforts related to this. Just curious if you can in the chat. So when we conducted this analysis, we looked at municipalities and states across the US. I understand that there are also organizations that have passed declarations outside of governments, but we were focused on governments. And American Public Health Association, their website, yes, thank you for that, Carol. Their website continues to update this. And so we reviewed legislation through September 2020, and we found that the majority of policies name racism as critical in addressing racial inequities in health, but there were limited details about any actions, limited details about funding, resources to actually execute the work. So to some degree, is it a name or what is happening? And so I think of this also as an action step for us in the public health field and in your respective regions as an opportunity to really, understand and assess these policies, right? Once they've been enacted, what is the content of that legislation? And then what actions have been put in place to address racism as a public health issue in your region? Some of you in the health departments may be working with your municipalities on actually operationalizing, right, this legislation. And then for those who are, obviously epidemiologists and data scientists and using mixed methods and narratives and qualitative work, what data or what information can you use to track and monitor progress of racism as a public health crisis in your region? So that's another action item. And then I wanted to also share one of the last sort of key tenets, the 3 tenets that I mentioned as racism as an ingrained feature, centering on the margins, and then praxis, right? This is this iterative process of critical self-reflection on the part of the researcher, practitioner, and advocate. How are forms of oppression and privilege operating in my organization as well, right? So this reflection is individual reflection on how do you come to this work, right? What is your positionality, right? What is your lens? How are you framing the work that you do? How are you engaging with that? And then what does that mean for the respective organizations that you may be collaborating with or working for? And then finally, I wanted to end with the centering wellness practice. I think with this work that we do, for many of us, is personal. It's not an esoteric exercise for me to just, this is what racism looks like on paper, but actually being from a community and being someone who experiences racism, from a community that experiences structural racism and knows that it has an impact on my health and well-being and on the communities that I love and partner with. And so what wellness practices do you incorporate into your daily life? Can you share that? Can you all share that with each other? What wellness practices do you incorporate? For me personally, I try and incorporate meditation in my practice. I have a dog, which you might be hearing him because he's going crazy because my partner actually has to leave in a minute. So the dog is just like going nuts. But my wellness practice is like taking the dog for a walk. It's getting cold here in Pittsburgh. So I'm like, burr, but that's one of my wellness practices. So if you can, just share what are some of the wellness practices? Yes, hiking, gratitudes in the morning, exercise, meditation. Thank you. Yes, continue to share because I think this is important that we, and I know tomorrow there's a whole session on centering wellness, but I think for those of us who are public health, those of us who are doing work on racism, forms of oppression, trying to address equity, living that out in our own daily lives and practice is important as well, and centering that. And so that's why I asked for you all to share. So much gratitude. Thank you. Continue to share walks, vegetable, gardening, bike riding, painting, fishing, therapists. Yes, mental health support, therapy. Yes, absolutely. How can wellness practices be incorporated into our work environment? Do we do collective wellness practices, right? Do we take breaks in time, right? Or we go, I know for me in this Zoom environment, COVID, for those of us in public health, I feel like I've been going 1,000 miles a minute, right? And so even on Zoom, right, back to back to back, time to breathe, right? Even in between, right? So how can it be incorporated into our work, into our environment to honor our full humanity? And then what would imagining wellness look like, right? Dismantling our current structures and systems, right? Because they are not built for us to be healthy and well, right? We know that walking into this work, right? But how can we incorporate that? Okay. All right, so I just want to share a couple of resources with you all. I know these slides will be available, or the video will be available, I think, after today. But two I'd like to share. There are, I think, a number, maybe half, who hadn't had an opportunity to attend the session on racism and health last year. The University of Pittsburgh has put resources in developing a asynchronous online course called Anti-Black Racism, History, Ideology, and Resistance. This is actually a required course for all freshmen at the University of Pittsburgh, but it is open to the public. It is online. And here is the link where you can read and watch video and look at additional resources. Another text, which is published by APHA Press, is Racism, Science, and Tools for the Public Health Professional. And this is edited by several folks, many of which you know. Dr. Chandra Ford, who I mentioned, is one of the people behind or has developed public health critical race praxis. So this is actually a framing within this text as well. And then finally, I'd like to acknowledge a number of my partners and collaborators. This work would not be possible. Teamwork makes the dream work, is what I say. I know it's a little cliche, but I stand here with multiple people beside me who've been able to really, do the collective work and continue to learn and grow with one another. And here's my contact information. Thank you once again for this opportunity to speak with you all during this session. I know we have went a bit over. I think we have about 10 or so minutes for Q&A. Thank you.
Please feel free to unmute yourselves and speak up, or raise your hand in the chat. Raise your hand in the reactions.
I see a lot of familiar names. It's so good to see you all. I'm like scrolling through, couldn't see everyone before. Dr. DeClercq, hey, good to see you.
I put
a question.
the evaluation in the chat too, and I'll put it in again, so you don't forget to evaluate the session.
All right. Yes, thank you. Hi, Kristen Rakin. Good to see you. See your name. I'm just shouting out. Thanks, Cheryl. Thank you, Nicole. Thank you, Caitlin.
I have a
and Roger.
question, if you
Yes.
want, about your real-time survey where people answer on the cell phones.
Yeah.
Is that well received? Do people get fatigued from answering them? And do they worry about their location being identified? Is that easy to get them to put that in?
Great questions. So it is an intensive protocol where they are completing surveys at the beginning of day, end of day, and random assessment through the day. There's a couple of things that we instituted in the study. One is they get to time. So it doesn't address the frequency point, right? But they do get to time their end of day, beginning of day, because there are a number of people who were, they time it based on, okay, this is before I leave the house, or this is once I get home. So there's some level of control there. We also had a number of, I would say elements that allow for people to pause when they need to, pause the EMA surveys coming to them just due to, other circumstances. And once the pandemic hit, we definitely saw a huge decline. We had maybe another 30 people who were finishing up in the study during the pandemic, when the pandemic started, who were just actually coming in. I take that back. Who were just coming into the study. And so, there's absolutely, the question of, just the ability to maintain during a pandemic when there's so much happening. And so we are looking a little further into that data. We also had some parts of our protocol which provide incentive. So we had a minimum of 60% that we asked people to complete the survey. So if they miss some, they have to be like, oh, I missed that one, or oh, so we did have some pieces in place with the understanding that knowing that everyone couldn't answer every survey all of the time. And then in terms of the location question, we only take location if they gave us permission. So there was a prompt that would say, can we take your location, as they were answering the question. So we did not automatically take their location whenever they were completing that survey. Does that answer all your questions about that?
Yes, thank you.
And yes, the question about R4P, so the slides will be available, and then you'll also see and I'll just say it again, it was from Vijaya Hogan and colleagues from the Maternal and Child Health Journal. So she actually has a publication that explains the sort of backdrop to R4P and dimensionality, and then includes those key elements. So I think that's a manuscript that is open access, I believe. Should be. And then just to kind of carry forward that question, the Betts equity typology. Okay, so the Hogan paper includes R4P and the HRIME, so the Hogan-Rowley institutional measure of equity. So that has an additional element. The Betts equity typology, which is juxtaposed with R4P, I included that citation. So that is a separate document. You can read more about that. We have a quiet group. No questions.
We might have a bunch of tired brains. That was so
I
much.
hear you. Listen,
I
it's
really-
5 o'clock my time.
Really appreciate this session. And can people contact you later if they think of questions when their brain's not tired?
Yeah, no,
You gave
absolutely.
the email address out, so.
Yeah, I'm gonna put my email in here. And then in the slides, my contact information is there as well.
Very good. I can't believe how many people are here and how many of them are sending wonderful compliments to you. So thank you so much for being with us. And
Thank you for having me. The privilege and honor.
We can give you 5 minutes if everybody's still shy.
Yeah, I guess so. No other questions. Maybe someone's waiting for someone else to ask a question. I don't know.
All right, thank you. I guess we'll sign off.
Okay, thank you, everyone. Enjoy the rest of the conference. Take care.
All right, you too. Thank you. Bye.